So without further ado, with a background in sort of nanotechnology and data science, I'd like you to invite a very intelligent young lady who can speak about 9 different languages, bearing in mind, who's going to talk to you about being beyond bypass and how we use data science to come and find different ideas of how we can improve outcomes. So Francesca.
Thank you very much. It's actually not that bad to have Richard as a supervisor. But okay, how do I do this? Sorry, how did I do the laser? Okay, welcome. Thank you for being here this early Friday morning. I'm going to talk to you about how we use data, or how we can use data to predict risk and understand surgical dynamics in cardiac surgery for both children and adults. And I would like to start off saying I'm not a perfusionist, so I'm sorry if I get everything wrong. But I will try to do my best with terms and stuff. So a little bit about myself. I'm based in London, as Richard said. I'm based at University College London and Great Ormond Street Hospital for Children. So that's where I'm doing my PhD, which is solely focused on pediatrics. I also work part-time for Orem Clinical Analytics, which you've seen around, I'm sure, and I will also spend part of my presentation talking about what I do in my capacity as a data scientist for them. So first of all, I want to start you off with a little story. I'm sorry for the gory pictures. I hadn't actually thought of that, but as most of you are perfusionists, I'm sure this will sound familiar to you. Let's say a patient, we'll call her Lucy. She's 2 years old. She has an AVSD, and she's coming in for closure. The surgery is going well. Flows are good. Lactate's low. Weaned off CPB without trouble, and everything felt as if it was going right. She went to ICU, but unfortunately, after a while, after a few hours, doctors started to realize that her creatinine was rising. Her urine output was not that high. And after a day and a half, we had to have a diagnosis, acute kidney injury. Now, although I'm not a perfusionist and I've never had this, for you, you've lived the story. You know that this happens. It happens in children. It happens in adults. And the question arises, what can we do? What can we do to prevent this from happening? What can we do to see it coming? And we've already had a few presentations about this, how to have mitigating strategies or better diagnoses for AKI. And I'm talking about this as well, as you can expect, but from a bit of a different capacity, because I'm talking about how we can use machine learning to try and predict which children are at risk of developing AKI and which ones aren't. Because eventually we just want all kids, after a successful surgery, to be in their bed, to sleep it off, to do whatever ICU doctors do to make them better, and to not have to go home with a new diagnosis. So obviously the KDIGO definitions for AKI are the most widely used, and in 2016 there was a neonatal expansion, which for pediatrics is very important. As you know, KDIGO staging is split in 3 stages that will have increased morbidity and mortality as you go to a further stage. Now, in my research, I've decided, based off of literature, to make a distinction between stage 1 and stage 2 and 3. This is because stage 2 and 3 have severely increased morbidity and mortality, especially long term. And as you can expect for children, young children developing AKI, KDIGO stage 2 and 3, if they have longer term effects, such as CKD, this has a great impact on a very, very large portion of their life. So we really, really want to mitigate children developing KDIGO stage 2 and 3. Now, KDIGO staging is amazing. It's given us a lot, consensus over definition, ability to do research in a different way and to understand AKI in a different way. But unfortunately, it's completely based off of serum creatinine and urine output. Now, there is a lag between the decline in renal function that starts and it becoming visible in serum creatinine and urine. And this lag can be quite long. It can be up to 24 hours or maybe even more. So this means that patients can actually be sick for quite a long time before doctors realize that they're sick. And this means, given that we don't really have good possibilities to care for AKI, it's not a good thing. We need to know beforehand that patients are going to get AKI or not. So there is a necessity for earlier detection, and that is where my research steps in. So here you see a timeline of surgery, and what I'm looking at specifically is the 48 hours post-operative period. This is the target period. So I'm only looking at AKI that develops based on KDIGO stage criteria in the 48-hour period post-operative. This is so that it basically, my research is mostly focused on the surgery itself and not the time on ICU. And I'm looking at whether a patient develops severe AKI or doesn't develop severe AKI. So I'm not looking at KDIGO stage 1, as I said previously. And this is where the important part comes in. I'm only looking at the preoperative period, or mostly looking at the preoperative period. That's the input period for my models. And the reason I'm doing this is because I want to create a model that can be used before the surgery has even taken place. This will enable us to have the biggest time gap, if you will, between my prediction model and the KDIGO diagnosis. And the bigger that difference is, the earlier we can detect which patients are at risk, the better for the doctors that can help the patients. In my research, I've also created a post-operative prediction model because we are interested in what the contribution of the surgery is on AKI and whether we can improve our predictions using the information from the surgery itself. But in this presentation, I'll mostly focus on the preoperative prediction. So in creating these models, we've taken a few things as, 4 things as our main, we've held on to these 4 things. So the first thing is preoperative use. So as I already said, we want to make sure that doctors can use these models as early as possible. Secondly, we wanted to focus on making the models openly accessible. Unfortunately, a lot of machine learning research ends up on shelves and doesn't actually end up in the hands of the people that need it most, which is you. Thirdly, we wanted to only use routine hospital data because not every hospital has the capacity of implementing complex machine learning models in their IT, and we want to make this something that everyone can use so that it can actually help as many people as possible. And lastly, we need to balance model priorities, which is something I'll get into a little bit later because it's the technical part. And I won't bore you with too much technical stuff, but because it's early morning. So in creating this preoperative model, we've used 3 different algorithms, machine learning algorithms, to try and see whether it was possible to do it with the simplest models possible. And in choosing them, we were trying to balance accuracy, prediction accuracy, speed of modeling, and simplicity. Now, I know that a lot of people think deep learning is a holy grail, and as a machine learning engineer, I can really tell you it's not. We want to use the simplest model available for our prediction because of the balance of these 3 things. So I'm not using deep learning. I've used logistic regression, which is something that probably most of you have already seen, which tries to set a probability in an S-shaped curve between 0 and 1 to do a binary prediction, in which, in this case, 0 would be not developing AKI and 1 would be developing AKI. I've used support vector machine, which is slightly more complex than logistic regression. It tries to fixate a hyperplane between the two binary groups, where the margin between the closest 2 points of the two different groups is as large as possible. Slightly more complex, but still one of the simplest machine learning algorithms. And then I used XGBoost, which I think we've heard a little bit about yesterday. It's a different type of machine learning. It's a tree-based model with gradient boosting, which tries to make an ensemble of different trees to get to its binary prediction. Now, as I said in the previous slide, we want to balance modeling properties. And one of the things that we really need to balance is the imbalance of data. We need to take that into account. And what do I mean by that? So we've heard yesterday that about 33% of the adult cardiac surgery population develops acute kidney injury. In children, this can be even more. This can go up to 40%. But since I'm only looking at severe AKI, and a lot of the patients that develop AKI actually develop KDIGO stage 1, I'm looking at a very small subset of my entire modeling population that develops severe AKI. And this means that my data is imbalanced. So if you look at the screen, you've got 20 people here, and only 20% of these people are sick. Those are the people that are Black. If you model the perfect way, which of course we try to do, you would model all 4 ill patients and you would predict them as ill, and all 16 healthy patients, you would predict them as healthy. This would account for 100% accuracy, and of course this is where we want to go to. However, this never happens. This is just not something that you can reasonably aim for. The problem with having a small subset of your population that you want to predict as ill, because this is the focus for us. The ill patients are the focus for us. We want to know which ones are ill. The problem with having a small part of your data set that is ill is that even if you predict everyone is healthy, you get 80% accuracy. That's because 80% of your population is healthy. So it's correct. If you just say everyone's healthy, then you're right. But your model doesn't work. Because in your model, you want to find these 4 people. You don't really care that much about the rest. So you need to balance that out. And the way that you do that is, if you look at this, you have a lower accuracy, but you've correctly predicted 75% of your sick patients as being sick. You've only missed 1. You've also incorrectly predicted 25% of your healthy patients as being sick. So that also accounts for 75% accuracy. But you've only missed 1 sick patient. So this model, with this outcome, actually does work better than your previous one, even when you say that the accuracy is lower. Now, this is one of the things that we need to take into account all the time while looking at our output, because it's easy to overlook this, and unfortunately, it happens a lot in machine learning modeling. So after this little data lesson, onto the results. So what is the accuracy that we have got in our preoperative AKI prediction? And now I want to stress again, we're trying to predict AKI before surgery, so preoperatively. Now we've managed to actually get to the state that I just showed you. So we've managed to predict 75% of patients that develop severe AKI as such before the surgery has even taken place. Unfortunately, we also predict 36% of patients that don't actually develop AKI based on KDIGO criteria. We also predicted them as being at high risk of developing AKI. But we're focused on this. This is, for us, the most important part. We'd rather predict some patients that aren't actually at risk of developing AKI as if they are at risk, because that doesn't really matter. They're healthy. They're going to be healthy. We don't want to miss the patients that actually are going to develop AKI. So why is this relevant? As you know, AKI is connected to longer ICU and hospital stays after surgery. So we went on to try that out on our data as well. In pink here, you can see the real KDIGO, the AKI based on KDIGO diagnosis. And you can see that there is a statistical difference between the group that doesn't develop AKI and the group that does. Now, interestingly, even though 30% of healthy patients get predicted as if they're at high risk of developing AKI, when we look at ICU stay, the group that we predict as not developing AKI and the group that we predict as developing AKI have a statistical difference in ICU stay as well. So even though we predict some healthy patients wrong, that doesn't affect this ICU postoperative length of stay difference. Actually, it even becomes more pronounced, the difference. There are several reasons that this can happen. KDIGO criteria are obviously only based on serum creatinine and urine output. We use a lot more data. So maybe other factors that contribute to longer ICU and hospital stays, we're also picking that up. But what this actually means is if you use the model before surgery, you can reasonably expect that if a patient is predicted to be at high risk of developing AKI, that patient will be on ICU for longer. Now, it's not a direct prediction, but you can correlate. One of the other things that we've done is look at what the model uses to get to its predictions. We do that by looking at the SHAP value of each feature. So here we can see that as we expected, age, weight, main diagnosis, and some laboratory preoperative values are big contributors for the model to come to its prediction. Now, I really want to stress here that this is not a causal relationship. This is just what the model uses to get to its prediction. As you could see before, the prediction is not perfect, so it's not a causal relationship. It's only what the model uses to get to its prediction. But still, you can see, given that the model still can predict AKI with a relatively high accuracy, these probably contribute to AKI in a direct or indirect way. Now, lastly, as I said before, I wanted to make sure that this model would become openly accessible and to be used by other researchers and clinicians. So we have created a web application in which both the preoperative and postoperative model are embedded, in which user can input data, and as you can see here, you can input whatever the patient has. You can skip if you don't have data. You can search for data. So it's a fairly easy to use application. And because the models are embedded in it in the back end, you can then run the prediction yourself. This will show you the output of both the XGBoost and the logistic regression. We've left out the support vector machine because that one actually didn't work as well. I want to stress here, this is not a clinical decision tool. It's on the screen. It's not a clinical decision tool. It is really only for research purposes to try and see if this actually works. We've also embedded the Shapley analysis in it, so you can see which factors the model has used to get to its prediction. Now, this can differ per patient. So if you have a very high preoperative creatinine, or if you have an urgent case, either of those factors could contribute more or less. So because this is not a clinical decision tool, it's not openly available on the internet, but we are creating it in a safe space for researchers. And if you are interested in getting access to this web application to try it out yourself, please scan the QR code. You can fill in your details, email, name, and what you would like to use this for, and then I can give you access. If this didn't work for any reason, please just come to me after this presentation. I'm around today and tomorrow, and we can make sure that you can get access. So as I said before, we created both a preoperative model and a postoperative model, and I just shortly wanted to touch upon that postoperative model as well, because what we found is that actually the prediction accuracy goes up a little bit when we add some perioperative features to the model. Now, this was to be expected because, as you all will know, total bypass time does have an effect on whether, has already been shown to have an effect on whether a patient develops acute kidney injury or not. And that's exactly what we have seen in our SHAP as well. Total surgery time, the last lactate in surgery, total bypass time, these are all features that are important. And this is what the rest of my PhD will also be focused on, because we want to assess what the surgery itself, what the contribution of the surgery is for a kid developing severe AKI. And we want to take the time aspect of the surgery into account in that modeling. So that was the part of my presentation about the PhD. And as I said before, the temporal aspect of the surgery is probably very important. And I have had the opportunity to actually look into that a little bit more within ORAM, and specifically looking at consistency in perfusion. Now, this part is all going to be about adults. So the first part was about children. The second part is about adults. So within ORAM, I've had the possibility to look at consistency and specifically at trying to quantify the relation between consistency and outcomes. And one of the things that we want to, one of the reasons that we want to do that is to be able to embed that in the dashboard that we are creating so that we can actually relate this consistency measure, if you will, back to you to show you how consistent you are. But that arises the question, what is consistency? We've defined it in two ways, or with two overarching subjects, basically. First of all, the intraoperative consistency, so how stable are the vital signs during the surgery? And secondly, the interoperative consistency, how stable is your care across surgeries? And I will talk about both of these shortly. So first of all, the intraoperative consistency. What we're looking at specifically is guideline compliance and standard of practice. So in the case of guideline compliance, we're trying to embed the guidelines, the latest European guidelines, into this measure. The way that we're doing this is to try and get the level 1 class A, I hope I said that correctly, the quantifiable recommendations that are level 1 class A into this measure. We're trying to relate back to you, the perfusionist, whether you are actually being compliant over time with them or not. And the second thing is standard of practice. Of course, it's important that there are two things important in medical care, whether you give good care and whether the care that you give to each individual patient is the same. Because you don't want to have, I don't actually need to explain this to you, you're working on that. So we try to relate that back to you. What are you actually giving the same care to all patients across your hospital? Is a perfusionist always working in the same way, or are there big differences over time? So that is in the intraoperative consistency what we focus on. Secondly, we have the intraoperative consistency. Now, in the intraoperative consistency, what we're not looking for is, we're looking at the different vital signs. So just a usual one, mean arterial pressure, DO2I, hemoglobin over time. What we're not trying to figure out is what the right number is that you should be on. We're not saying, okay, you should have your DO2I at 280 at all times. What we're trying to figure out is whether a stable time series has an effect on outcomes. And there are various ways how you can define this. So one of them is, for example, looking at the maximum and the minimum value that you've had during the surgery, or how often you go up and down, or as I think was talked about yesterday, whether you have any outliers. But all of these things need definitions. You can define outliers in a trillion different ways. And that is what we're looking at. What we also are looking at is what the best time period is to look at. Are we looking at the whole surgery, or are we only looking at the cross-clamp period? Because frankly, as a perfusionist, that is when you have the most power to actually do stuff and change stuff. And lastly, we're also looking at which patients to include in this analysis. There are different ways, there are many different types of surgeries. And of course, comparing a mitral valve repair with a heart transplant might not always be what you want to do. So we're assessing whether it is a good idea to only include core procedures in this consistency measure. Now, core procedures are common STS procedures, I think, and non-emergent, non-urgent, non-redo. The reason that we chose to start our analysis with just these procedures is because you then have a comparable base field in your procedures. You can actually see if there is a difference in how consistent or how stable your vital signs are looking at similar types of procedures, because a heart transplant will probably be less stable, and that is fine because it is a more difficult procedure. So that's why we mainly are looking at these core procedures. Now I can give you a little insight in what we've found so far. This is still an ongoing research, but one of the things that we have been looking at is what the impact was of intraoperative DO2I variation on AKI outcomes. And I say variation because we haven't been looking at outliers. We've really been looking at how much variation there is over time within the cardiopulmonary bypass period. And what we found is that there actually is a relation between how varying you are, so how much you go up and down basically, and whether an adult develops AKI or not. Now, there's a lot of research to be done, and we're very keen on trying to figure out what the other relations are between the other vital signs and AKI, but also other outcomes. And as I showed you before, we're very excited to then implement this in the dashboard to then be able to relate it back to you. And I personally am also very excited to see what the difference is between adults and pediatrics, and see whether the variation and stability within a surgery has a different effect on adults and pediatrics. But that's all research that still needs to be done. If you have any questions about it, of course, come and see me after this, and thank you very much.
So thank you very much. I will take my moderator hat off for a moment and put my supervisor hat on, and just say that part of doing this, and I have to do it, is to make sure that your ego is just that little bit less than mine. But with that in mind, and I don't tell you this very often, I'm very proud to be your supervisor. You're an incredibly intelligent woman, and it's a pleasure to work with you. So now I've done that, I'm going to ask people to ask very difficult questions, but well done. It's not easy to get up there, and that's the first time you've done it, so well done. I think that's really awesome.
Thank you.
That's enough being nice. So as a moderator, any questions from the floor?
Francesca, for the average clinician in the audience, if they're using that tool in a research fashion that's available, that's directed at pediatrics, they can leave different fields blank. How can someone understand, from a layperson's perspective, how does the tool weight those blank? How does it take that into consideration in the confidence of the prediction, not the statistical confidence, but the confidence more globally, I guess might be a better way to put it.
Yeah. Thank you for your question. So in creating the model, we have excluded any patient that had more than 10% of their data missing. And that means that we still included patients that had up to 10% of their data missing. Before creating the model, we've imputed those blanks. And we've done that in it's a model in itself to actually impute those blanks, where this model basically learns, okay, in this combination of other fields, this is what we expect that value to be. We can save that and we can use that on new data. So that is how we impute blanks. Frankly, if you have more than 10% of the data missing when you use this tool, we cannot guarantee that the outcome will be good, because you're not doing the same thing as what we did when we created the model. But up to 10%, we can be frankly sure that, because that's what the results are based on. So yeah, I hope that answers your question.
Francesca, well done. How did you choose the physiological markers that you have in your model?
So partly based on literature, other research that has been done before had shown that, of course, creatinine, lactate, albumin are all important laboratory values, but also age, weight. They've all been shown before to have a relation to acute kidney injury. We had a very, very large data set, and it kind of was a back and forth between trying out different things, seeing whether there was a relation between features individually or in combination. And yeah, I guess it is machine learning is for a very large part trial and error, and especially in trying to find your features, that's definitely part of it. But we've tried to start off with the literature and then add on new features based on this trial and error.
Hi, thank you so much for this presentation, really nice. I have a question about the following the guidelines. So how do you find, sometimes we as perfusionists have to do things that are outside of the guidelines because they're just guidelines, but how do you manage to get a score of, we follow the guidelines, but we have to do different things because a surgeon wants more cardioplegia, or I only get the patients that are frail and have a lower starting hemoglobin, for example. How do you balance that between making cookbook perfusion and personalized approach?
Thank you for your question. I think in the field of medicine, we need to be very careful with trying to get to 100% or a score of 10. I think one of the important things is taking that into account, so you're never going to be fully compliant, and that is fine. By only using core procedures, though, you take out a large part of the cases where you might have to do things differently, and you might have to not use the guidelines as a reference. At the same time, we're looking at whether you're doing it stably over the course of various surgeries. So compliance, one of the guideline recommendations, I think, is not to have your DO2I under 280. That doesn't mean that if a case has 1 minute under 280, you're not compliant. So we are looking at whether over time, in your cases, you're doing the same thing. So, for example, looking at, okay, most of your cases have 5% of time under 280, but then all of a sudden you have one case that had 50% of time under 280, you might want to look at that because that's all of a sudden not consistent anymore. That's the kind of conversation that we would like to entice by this measure. And the reason that we make a measure is just because it needs to be readable, it needs to be understood fast. So I hope that answers your question.
And I would also make the sort of clinical point is that actually a lot of the guidelines that are coming out, they have suggestions and they are very low quality data that support it. So part of the idea of looking at this is to see, well, if you do follow the guidelines in real world data, does it make an effect? So what Francesca is looking at doing as much as anything is to say, well, can we find evidence to support the research that we've already got? Is there enough evidence that we use realistically that will actually, give an answer of actually that doesn't really make a difference in the real world? And I'm actually going to sort of ask Rob, if you want a sort of question, but we've been chatting about data and what we do with it. And I think, if anything, it highlights from Francesca's point of view the idea that we should actually collect more data. In fact, we should collect everything so that we can find out what is important. Because we have ideas about, well, maybe this is quite useful, maybe that's quite useful, partly because that's all we know. And if you don't actually have the data to hand, you won't know whether it's important. Now, so I mean, you can comment on this sort of the size of the values. You said you had a large data set, but maybe sort of put it into context.
Sorry?
So how many patients did you have to actually work on?
So we have about 10,000 core procedures that we can look at, and more if you include other procedures, and it depends a bit which vital sign you look at. But yeah, I would say 15,000 patients that we look at. And I think one of the other things that also relates to this is whether we look at just the cross-clamp period or at the whole surgery, because a lot of these non-compliant, if you will, moments are actually at the start of surgery. So we also have the option to exclude that, if we would.
So I have two questions. One, this is a pediatric predictive model. Are you working on an adult predictive model as well?
Not within the scope of my PhD, since my PhD is funded by a GOSH charity, which I'm very thankful for, but that would be within the realm of pediatrics. This would be something that I could work on with my Orem hat on, as Richard would say.
So I just opened the app on my phone, and on my phone I have 10 adult AKI predictive models. How, as a clinician, what should we look for in choosing the appropriate model or a model that's good for our practice?
So a lot of that is, of course, looking at the research behind it. Unfortunately, what I've found is that a lot of models don't actually take the data and balance into account when creating their model. So they'll report back a very good ROC and a very good accuracy, but frankly, you don't really know, because as long as you don't show how sensitive your model was to sick patients, you don't actually know how useful it is to you. So that's definitely one thing that I would look for. There is more research on AKI in the adult field, and the reason that we've decided to go in this direction in pediatrics is because in pediatrics there are models out there, but they're all behind closed doors, and that's the reason that we have decided to create the simple model for pediatrics. A third thing that I would say is that a lot of the adult models are also based on complex data, and if you have to input a time series to get an output, then you've lost 90% of hospitals. They won't actually do it because either you can't get to the data, or it's too complex to actually put it in the right format and to run the model. So simplicity is another key factor.
Unless you would say, I have to understand it, so we have to keep it simple. One more question? Yeah.
Francesca, that was a lovely presentation. One of the questions people often think about is, you've developed a model, you were very clear at the bottom of the slide to say it's a research orientated model. But in the real world, clinicians look at this sort of thing. So at Greater Ormond Street, what's the relationship with the clinicians in terms of what do they think of the model? How are they considering putting it into their practice? What impact would you guys consider it may have? I mean, it seems to me that the ability to predict is one thing, and then we need to work out how to use that prediction to help the outcome.
I don't know if you also want to weigh in on that, but I think one of the ways that within Great Ormond Street we would like to use this is to, first of all, keep use of prediction before the surgery, and then keep an eye out on those patients, see whether actually in practice we see the same thing that I found in my data. If that is the case, then for those patients that are predicted to be at high risk, you can start maybe giving them less nephrotoxic drugs after surgery, or maybe more water. Now this starts to be the clinical part that I don't actually understand, but there are some things that are general practice in ICU that are actually not very good for the kidneys. So you could start trying out to not do that for the kids that are predicted to be at high risk. That wouldn't affect those kids if then in fact they don't develop AKI. But if we then see our AKI rates drop, that is the moment that we can try and make it a clinical decision tool, not based on doing a different practice within the surgery, but based on mitigating strategies, really.
Yeah, I'll add a bit of clinical aspect in terms of, we listened to Professor Landoni yesterday about, using amino acids and things like that. So if you could, essentially predict which patients are sort of really high risk, then perhaps you can utilize these other strategies, saying, actually, this is worth trying this to try and even if you just reduce it down, so let's say from stage 3 to stage 2 on the KDIGO scale, that will have massive ramifications in terms of how long they stay in ITU, how long they essentially block a bed for. That's one of the major issues that we have, is that you try and get children through and out as quickly as possible. So you can keep going and making sure everybody else gets an operation. But if you have patients that are going to languish on ITU requiring renal replacement therapy or anything else, that becomes a major issue, and it's a huge cost issue as well, and not just in terms of finance, but in terms of long-term outcomes, as we heard, in terms of the CKD and what have you. Sorry. So I think that sort of element is very important. So we have worked quite well with our consultant intensivists in doing this, and they made a very valid point, which is that you can't necessarily take renal replacement therapy as an outcome, because that's very much dictated to by whichever consultant is actually on, or registrar or intensivist, I don't know what you typically call them in the US, but whoever's in charge of the ITU. Some people go straight into it, some people are a bit more conservative. So this is very different in different aspects. But if you can do that based on laboratory results or biomarkers, then you've got a better way of actually being able to sort of classify this.
Given the public reporting of outcomes for cardiac surgeons in the UK, have you considered putting surgeon into the model?
I couldn't possibly comment, but if you buy me a drink later, I'll tell you all about it. I'm sure that's something we yes. And again, I think that this was talked about yesterday in terms of actually you have these peaks and troughs when somebody new joins the department, mortality rate goes up. I think there's a Gil that mentioned that. And so it's difficult sometimes to sort of, we try and classify them as it's their fault, but that's not necessarily always true sometimes. But I think so it's very difficult in order to take those things. But there's the other aspect is that we try and classify pediatrics into sort of groups. The reality is actually there's so many more kind of complications underlying it that actually no two patients are ever really the same, and that's just from the the point of view of the anatomy, the physiology. So it becomes incredibly difficult to say, well, that is the surgeon's fault on all these different patients who have an AVSD, because an AVSD can be very, very broad spectrum. So it becomes very, very complicated to do that. And actually, to be fair to them, there's not a huge impact in the surgeons, at least we have. Now, whether we did that across the world, you might find one or two come out more badly than others. That's remains to be seen. But at the moment, it's not giving a hugely strong signal.
It would make the model unusable as well for anyone outside of the hospital that you're creating the model for. So.
Are there any further questions? No, in that case, I think well done. Thank you very much. And